Tonight, we are going to look at the topic of pain in PKD, the causes and some things that can be done to manage it. Now, I can say on behalf of Dr. Yuki, we can't give you a magic wand and a cure-all. Unfortunately, we'd love to be able to. We know pain can be debilitating for so many of our community, but we don't have that magic wand. So tonight on the call, there's myself, Susan Muirhead, as many people will say, the Scottish lady. I am Support Services Manager at PKD Charity. I'm joined tonight by my colleague Jane. Hi Jane, do you want to give us a wave? Jane.
Hi, everybody.
You've maybe met through our events or communications. That's usually Jane that's behind that. And we've got the lovely Dr. Yuki Heath, a speciality doctor in renal medicine from the University Hospital Birmingham. I had the pleasure of meeting Dr. Heath in autumn when we were down there for a patient information day, and I may have met some of the audience that day too. So lovely to have you. As always, we have to say that we do receive lottery community funding. That is due to come to an end next month in February, and we very much appreciate the 5 years of funding we have received. Now, I maybe sound like a broken down record, but we will ask you at the end of this to give us some feedback. For us to secure future funding, we very much have to show the impact of the work we do, and that impact comes from these little surveys. They only take a few minutes of your time, but they are a gold nugget for ourselves to use to show the impact of the work that we do. So please take that moment. We'll be sharing those with you later. We obviously have to do, and I'll say it in the medical disclaimer, and you're thinking, we've got a doctor on the call. I'm saying we can't give medical advice. Obviously, this meeting is for information purposes only. It's not a substitute for professional medical advice based on your own symptoms, your own medical history, and any medical advice should come from your own care team, whether it's your GP or renal departments. Remember, you can always talk to your pharmacist, and I think for many of us, a pharmacist is now our first port of call, where we can walk in without having to telephone and arrange appointments. I find my local one very, very helpful. We always make the thing for using Zoom. For some of us, it's new. Some of us use it on a daily basis. So this little slide, if you want to maybe look at your own screen, it helps you recognise what to do. Tonight, Dr. Yuki will give a presentation. It will last approximately 20 minutes. Thereafter, we will go to question and answer session from yourselves. The easiest way to ask a question is if you click on the chat, the little speech bubble, you can type your question in there, and Jane and I can ask it on your behalf when we move to the question answer session. If you're feeling bolder, you can raise your hands and ask a question live. Now, do bear in mind, if you do that, your voice and your image will show on the recording. So just to make you aware of that. And also, if you do have any follow-up questions at all, our email's there, but we will drop that into the chat, the info@email. What I'd like to do now is just hand you over to Dr. Yuki Heath. Hi, Yuki.
Hello. Thank you for having me. I'm a Dr. Yuki Heath. I'm a renal doctor in Birmingham University Hospital. So today's topic is pain in PKD patients. So let's go over it. But for the first, I want to say people's symptoms are so variable. Depends on patient from patient. It's so different. Even the images looks same. Even the variants, is the same, but it's so different. So trigger of the pain threshold is so different. So I'm gonna just try to cover every topics about the symptoms, depending on the patient, but it's not necessarily the case with each of the case. So these major symptoms I just get that from the PKD charity site. So patients have got a lot of symptoms, but so you see reduced kidney function and the high blood pressure on the right corner. That is only two things usual nephrologists know really well, but not necessarily other five symptoms. It's a lot and it's really disabling to some patients, but nephrologists usually don't know other than those two things, let alone GP, let alone A&E doctor, let alone other departments don't know. Even nephrologists don't know much about this unless you see the patients constantly, intensively, and then you see how disabling those five things. So that's kind of, you have to understand the NHS settings. And so, yeah, can you click the next one? So I'm going to go over those five things. And then the first one, abdominal discomfort and bloating and the kidney pain is basically chronic pain. And the other three, tract infection, cyst, stone, is acute pain. And I'm going to go to the chronic pain first. So kidney pain is is a thing, so that this two kidneys, left side, obviously normal kidney. Can you go next one? You go back to, yeah, so this one. So the left side, the normal kidney, is usually this size. It's the fifth size, 10 centimeter in length. But PKD patients has got genetically programs inside the kidney. The cysts try to grow gradually but steadily every day in a microscope level. And then this is a growth, isn't it? The cyst grows gradually, and then the kidney is encapsulated quite tight band. And so if the inside the kidney, the cyst always try to grow. And then remember, cyst is a filled sac. It's a really solid, quite hard. It will always try to enlarge the kidney and depress the real parts of the kidney. That can really kind of uncomfortable feeling because you're stretching the capsule. And the capsule has got a nerve. That's why you feel discomfort. That is a kidney pain. And also, remember, you can have a pain from other causes just like anyone else. And the pain is one of the most challenging symptoms to address in the Western medicine. Western medicine is most advanced medicine, but Western medicine is not at all perfect, isn't it? The pain is one of the best, the challenging parts we can't address really well. That's why pain management team is really struggling. There's lots of long waiting list, usually 6 months. Can you imagine the pain if we want to cure, but they have to wait 6 months? That's why so many people in suffering from pain, regardless of PKD or not. And then on top of that, PKD patient has got this problem. So it's all come from growing cyst. It's a kind of physical thing. And can you do the next one? So the bulkiness of the cyst collectively cause various symptoms. So I usually feel visual explanation will sometimes help to understand what's going on in your body. So let's think about your body. So this is a picture on the left side. Inside the body, there are lots of organs, isn't it? And the organ can be divided by solid organ, for example, liver, kidney, spleen is a quite solid organ. They're not going to move, and they're quite bulky. And then between those, there are tube organ, hollow inside, pipe organ, I could call. So this tube organ starts from the basically gastrointestinal tract. So starting with the mouth, gullet, stomach, duodenal, small intestine, colon, anus. Those are all pipe organ. So they have to move. Their function is move around the food from one place to some place. So they have to move around freely. And if they can't move freely, they can't really give you cramps and spasm. That is cause trouble. So let's look at the your body. So next slide, this is a little bit lower parts of the lung. So left side is a patient with PKD. Right side, patient without PKD. Now you can see dark part. So we are this is a cross section of the body. You are lying on your back and we are looking at your body from the bottom. So the right side is a right side, patient's right side, and the left side, oh, sorry, on the left, that is the right side of the patient. And then the right side is the left side of the patient, sorry. And we are looking at the patient from the bottom, right? So you can see the dark part is the lungs. And you can see the right side of the picture, dark side is quite a lot, isn't it, compared to left side. So this is a lower lung. So lower lung depends on the kidney size, cyst size. This patient's cyst is really pushing upwards. So this patient is really difficult breathing, especially breathe in, inhale deeply. So could you just click on that? Yeah, breathless, that cause breathless. And then also at between the gullet and the stomach, there's a quite nice tight, like an anus. So it have to be tight. But this part can be pushed from the below, because of the cyst, and then go up to the lung area, so that the nice tight entrance can become really loose. That can cause acid reflux. So this is really caused by basically bulkiness. The next slide, please. Next, yeah. So this is a little bit lower part, so upper tummy. And then you can see that this patient have got cysts in the liver. Basically, cysts in the liver, cysts in the kidney behave the same way. And up to 80 patients of PKD patients have got cysts in the liver, ultimately. And usually cysts in the liver doesn't cause trouble, but this patient has got quite a lot of cysts in the liver, isn't it? So there's a bulkiness. Can you imagine, can you see these, sorry, don't click on that. Can you see this, my arrow? Yeah, so this part is a dark part, yeah, is stomach. And then can you look at the right side? Stomach is full of gray kind of juice. So they can expand freely. But the PKD patient, if you cyst this kind of level, you can't, stomach can't freely expand. So can you click on that? Easily feel full because not much room there, because the solid organ together with the cyst is really pushing. So the abdominal swelling as well. And also because the colon, stomach cannot move around as they wish to absorb the food. So abdominal pain happens, depends on the patient's, a couple of hours after the food. Yeah, it's very physical thing. And next click, please. Next click. Can you do next click, please?
I think we've got a little technical hiccup here. You can give me a moment. Okay, there's just too much happening on the screen at the moment.
Okay. Yeah, next screen is
still showing I'm sharing, but the screen has disappeared. So give me a second.
I see. Sorry.
Not a bother.
So maybe audience can have a look at the images. Images really helpful for understanding.
What I'm going to do, I'm going to stop sharing and we'll reshare.
Yeah, thanks.
While we've got this little delay, Yuki, do you want to take a question about this particular slide if anybody's got one?
Yeah, if you want to ask.
Well, I think that's us back live now. Perfect.
Right. Okay, so let's back on. So this is the lower part, almost like navel area. So you can see clearly on the left side of the picture, there's not much room. So almost 80% of the abdomen is taken up by this cyst. In this patient, cyst in the kidney, cyst in the liver is taking up the space. So not much room for the colon move around, not like the right side of the CT scan. This patient without PKD has got lots of room, isn't it? So they can move around to the pipe organ. The pipe organ can do their own work freely. But on the left side is usually, so patient usually easily can feel cramps and spasms. So can you click? Next one. I guess you're clicking. Well, hiccup again. Yeah, so abdominal discomfort, bloating, and also because of the bulkiness, you are like a heavily pregnant woman, isn't it? And then this cyst, remember, is a fluid-filled sac. It's quite heavy and so difficult to move quickly. Okay, right. Okay, next slide, please. So this is let's continue. The bulkiness causes various symptoms. So this is again, the upper side is a patient. We are looking at the patient from the left side. So you can see the brain and then spine. Could you click? Yeah, so this two pictures. Right side is a patient without PKD. And the left side, patient with PKD. You can see spine and then lots of cysts. And then you can see part of the cyst, lower part, is the cyst is pressing the spine, isn't it? Can you click? So back pain or slipped disc, depends on the cyst position due to posture change, facilitate degeneration, which is aging of the spine, change in posture. So it can cause musculoskeletal pain. Oh, sorry, this is wrong. Spelling, isn't it? Yeah, next one, please. So this again, the lung, you can see the right side is a patient without PKD. Left side is patient with PKD. It's a little bit subtle, but just look at the lower side of the lungs. There is not much room on the left side, so you can't breathe deeply because of the cystic is pushing. Yep, can you click? Yeah, this can go shortness of breath again. Yeah, okay, next one. So in summary, the bulkiness of the cyst causes various symptoms that the cyst is going upwards, downwards, forwards, backwards, sideways, and anywhere they can go, they go, and really they are soft. So they are really pushing the tube organ. This is the left side is a patient with PKD. The right side, patient without PKD. There's a much difference, isn't it? Yeah, so feeling fatigues because of the heaviness, lower joint pains because the heaviness is taking a toll to the kind of heaviness to the joints. So that's kind of aging process is facilitated, isn't it? Yeah, so that is chronic part. And then on top of that, you have got acute pain. Can you click on that? Yeah, so acute pain, there are only mainly three causes: kidney stones, or cyst infection, or bleeding the cyst. And then kidney stone usually doesn't cause trouble to many patients, usually 4 to 5 patients. So I'm gonna go into that later on. But kidney stone is quite how to say, specific entity. So it's quite rare if you are not told you have got kidney stones. It shouldn't cause trouble. If you have a sudden pain, it can't be a kidney stone. If you haven't been told you have a kidney stones. Next one, cyst infection is you have a pain, but you have to have a temperature. So could you click? Yeah, you have to have a high temperature. So if you are not told you have a stone and you have a pain but no temperature, that means almost all the cases bleeding the cyst. Can you click on that? So this is the most kind of common cases. If you have a sudden pain, you have a chronic pain, like I said, and then if you have sudden pain, usually just check, think about, do I have a stone? I've never been told. It's very unlikely. And if you have a temperature, if you haven't got it, this is a bleeding cyst. This pain doesn't require any medical attentions. So people, if you don't know this, people go to A&E or GP, and then such a pain. And then, as I told you, pain is very difficult to measure. It's no objective marker. So it's all subjective marker, isn't it? And then even nephrologists don't know much about it. Let alone A&E doctor don't know. And then you just check urine sample, there's nothing, there's no blood. If the cyst bleeds is not connected to the ureter, there's no blood and there's no infection, and kidney function is the same. What can we do? And so the patients just end up in 6 hours, 8 hours waiting in E, in the pain, and then just only given tramadol at best, one tramadol, and then bye-bye, this is musculoskeletal pain. Good luck. That always happening. So if you know bleeding assist, you don't have to go to A&E. They're not going to help you. So if all you need is pain control. Okay. And then I'm going to just talk about a little bit of kidney stones. Can you click on the next slide? Yeah, so a little bit of stones in ADPKD. So one of my patients has got much pain, sudden pain, and that kind of significant of pain make me feel maybe stone. And we haven't got the ultrasound recently. So the GP did the ultrasound. Can you click on that? So this, yeah, you can see in the black dots, yeah, there is something there, isn't it? And then even ultrasonographer said this is maybe stone because she's so much pain. Together with clinical symptoms and this picture, they said stone. And then she came to me and I did a CT scan because I thought it's not kind of typical kidney stone. So can you click on that? When we did the CT scan, there is nothing there. There is a little white part there, is it? White part, isn't it? This is a calcified area of the cyst. When the cyst bleed, that can be cured with calcified area. So there's nothing there. So basically, basically bleeding the cyst is usually self-limiting within a couple of days, at longest 1 week. But this patient has got several weeks pain, much pain. So she took a lot of painkiller. But then later on, could you click on that? Click, yeah, this is a cyst bleed, but the presentation is really like stone. So click on it, please. Yeah, quite tricky to detect stones in specifically ADPKD patient because ADPKD patients have a lot of calcified cyst. Next one, please. Yeah, so stones only cause pain when they cause obstruction, usually. So the stone itself doesn't cause any trouble. But if the stone, like this, in the middle of the picture, if the stone fall into the ureter and get stuck, and if you block the urine flow, then the collecting system is something wrong. They will try to push. That cause cramp spasm, and it is really typical pain. You can't sit in 1 second, can't just sit. It's so typical pain. It's a little bit different from the bleeding assist. Bleeding assist is because already quite pressured inside the kidney, and then suddenly bleeds happen. That cause more pressure suddenly. That is really cause pain. So stone, could you click on that? So management, basically drink plenty because the kidney is the organ to concentrate everything. So any concentration can be crystallized and then become stone. So you have to drink plenty. So basically, we usually drink 1.5 liters a day, but twice the fluid, yeah? And the pain management is a little bit tricky. NSAIDs, usually people say don't take NSAIDs, but NSAIDs like ibuprofen, not gel, ibuprofen tablets or diclofenac tablets, is really works well on this kind of pain. So you can take this very cautiously. Very cautiously means you drink a lot. If you drink a lot, usually it doesn't cause damage to the kidney because basically NSAIDs is strangle the kidney. And if you are dehydrated, it's really damage the kidney. But if you drink a lot and if it's pains so much, sometimes it works. Up to 3 days, it's okay, it's cautiously. And the tamsulosin is a detrusor of the ureter's relaxant, sometimes work. Warm compress works, but you have to come here if this is a stone. And you know you have to have you know beforehand you have a stone because you definitely have some images before, and a stone is very quite striking at this level. So in case you pass the stone, please collect it and please bring to us. because we have to analyze this. Stone can be caused by 3 causes: calcium oxalate, uric acid, or both, or struvite because of the urine infection. So depends on the cause, the prevention is different. But whatever cause is, drink plenty is the most important things. Next one. Yeah, so those upper 2 pictures, the left side, right side, the same person in a different time. So 1 year ago, this patient hasn't got much stone, but in 1 year, he has got lots of stone. Yeah, that and that. That really looks like a stone. So it's very typical. It's not calcified area. It's a kind of little bit chunky, isn't it? And then the left lower side, you can see clearly like a stone kind of circle. This is the stone. If you are not told you have this stone, you don't have a stone. Suddenly, this patient is always going to have a stone repeatedly. And usually people have stone repeated. Like half the patients in 1 year, you have it. And then the right lower side of the ultrasound, you can see quite bright part, isn't it? This is the same part of the upper right. So this is a different, isn't it, from the ultrasound before? So the stone is a little bit different. Only 4-5% have got the problem. Next one. So now I went through chronic pain and also acute pain. Basically, chronic is a cyst growth is causing trouble, and on top of that, cyst bleeds. That's cause pain. That is a very common case, and the people think, how can I remove? Why can't I remove this cyst? This cyst causes so much trouble. But the thing is, kidney has the real parts of the kidney is mingled with the cyst. That's why we can't remove only real parts of the kidney, and the cyst is so mingled, isn't it? But some people can have quite dominant cyst. In that case, we can remove it. So the first case, can you click? So this patient has got, you can see the 2 kidneys, and this patient has got quite high BMI. So this one is a gallbladder, sorry. Upper part is a gallbladder, but the right lower parts of the cyst is a cyst. And then this patient has got high BMI. So by the way, this patient has really high BMI. So there's a lot of fat, organ fat, isn't it? And then organ is really floating in his fat. That's another story. But this patient has got a only one dominant cyst in the left kidney. Yeah, this one. And then this will cause him really trouble. And this patient is a little bit atypical for ADPKD patient, because ADPKD patient has got lots of small cysts, but this patient has got the quite dominant cyst in the left lower back, and this really causing trouble. And he came to the A&E renal assessment unit every week for the last 6 months, and then he was referred to me, and I just did have a discussion, and it sounds this particular cyst is causing really pain, and he's on quite lots of morphine patch, but it didn't work at all. So I decided to do aspiration, and can you click on that? So this is after aspiration. There is nothing left there, isn't it? The left kidney, the cyst gone, and then miraculously the pain gone. He doesn't need any morphinated patch or anything, and then he go back to the lorry driver because he couldn't work anymore at the first time. But now he coming back to once a year, so it's no problem, nothing. Next one. This patient is quite aggressive cyst in the liver, and the cyst in the liver, it just occupied all his abdomen, and he couldn't anymore eat because of the cyst bulk. He couldn't work, he couldn't have a quality life. So after a long discussion in a multidisciplinary team discussion, we decided to do remove the liver and then transplant. Can you click on that? He got a transplant, so all the liver removed, and then new liver came in, and he's now, so we left it, the cyst in the kidneys, but he's quite happy. He's now gaining weight, he now has a life, but he has a liver transplant. Next one. So this patient is a left kidney is a really trouble. Left kidney is always bleeding the cyst, and also cyst infection, and it's always caused trouble. And she couldn't work anymore because of the pain and the infection, and she was really miserable because of the pain. But the problem is, this kidney, both kidneys, has got real parts of the kidney between the cysts. And then they were really making efforts to urinate, to make a urine, isn't it? But after a long discussion, she said she really wants to remove the kidney. So after multidisciplinary discussion, we decided to remove left side of the kidney. But the problem is, both kidneys has got 50%, 50%, I'm going to say percent. It's not particularly precisely percentage, but it's a milliliters per minute, but I'm going to say 50%, 50%. Both kidneys make 30% of kidney function. But if we remove left one kidney, it's going to make her 15% of the kidney dysfunction, isn't it? So can you click on that? So we removed the left kidney. She said it's good because there's no pain from that kidney. But at the same time, she really suffered from uremia because you lost suddenly 50% over hours. That's really taking a toll. Because if your kidney function going down like this, it's bad, but it's very gradual. So the body can adapt really well. But if you just remove 50% suddenly, it's a really taking a toll. So she said, pain gone, but really tired. But she did not regret. So can you click on that? So her kidney, basically, because the cyst growth is so aggressive, the kidney function going down quite rapidly, whatever we did. So at the last part, we removed the kidney. So that's kidney function from 30% to 15%, like a calculated way. And then 1 year later, she reached end-stage kidney disease. She's now on dialysis. Now she's working on live donor transplants. But she doesn't regret. But this is the caveat. You have to think about that kidney has got the real parts of the kidney between the cysts. This is a really extreme case. So usually PKD patient has got cyst pain, but it's not that extreme. So pain control is the most important. Can you click on that? Yeah, so this is the last slide. So I always ask the patient pain scale and discomfort scale and the 0 to 10 scale. Like I said, the pain, there is no objective marker. So you have to tell us how significantly disabling your pain is. So when we ask 0 to 10 scale, 10 is massive, unimaginable pain, and the 0 is nothing. If you think, have a think, if you think your uncomfortable feeling and pain is more than 5 or more than 5, it's really disabling. It's very significant. So you have to do something. You shouldn't, my opinion, you shouldn't, endure this pain if it's more than 5, 6, 7. So basically, first, supportive. So topical pain relief, any cream is okay because it's not going to be absorbed systematically, significantly. So any topical things you can use, even NSAIDs cream, that's okay. And then if it doesn't work, step 2, simple painkillers. Yeah, you can paracetamol, and then if it's, first when needed, but if it's so chronic, you can take it regular. If it's your body weight more than 50 kilograms, you can take 1 grams, basically 2 tablets up to 4 times a day. Regular is sometimes better. But if it doesn't work, paracetamol plus morphine related medication. So this is step 3. Paracetamol itself, it's not so powerful, but together with morphine-related medication, it's really complement each other. So I really recommend those 2 things have to do that because people think paracetamol doesn't do anything, but morphine medication and paracetamol really work well. So there's a ladder, WHO ladder, from the weaker morphine to stronger one, codeine, tramadol. Or patch sometimes really good because when you put the patch 1 week and the pain ease constantly, and you don't have to worry about should I take a painkiller or not? Shall I not? You don't have to think about that. And if you put the patch and it doesn't work well, you can take it off. But at least we try. So we want to try to find the good morphine. Doesn't cause much trouble, but ease off the pain. That is a kind of pain ladder. And then interventional step 4, I showed you. It's a really specific case. It's a very, have a long discussion, contemplation needed. Can you click on that? And also nerve pain, amitriptyline, duloxetine, gabapentin, pregabalin. It really works if it's neuralgic pain there, pinched now because of the cyst. And also tolvaptan is another topic, but tolvaptan definitely work for the pain. Some people somehow feel more pain, but a majority of the case, this should ease the pain. But if it's indicated, in the UK, your EGFR have to go down at a certain level. For example, 2.5 mils per minute, I'm going to say percentage, 2.5% loss per year over 5 years, or 5% over 1 year or 2 years, you are eligible. So because the cyst growth is quite aggressive and sometimes really work for the pain. That's it. 20 minutes, maybe not 20 minutes, sorry, a little bit over. I didn't have any room to just to see the question, but
thank you for a superb presentation there. I think you did safely cover many of the aspects of pain. The final slide that Yuki shared there about the interventions, that's included in the little leaflet that Yuki's kindly shared with us from Birmingham that will be circulated tomorrow. So that is just a little reminder, because I'm aware you can see like faces very concentrating throughout, and I think there was a few bits and pieces getting written down there. So Jane, is there any questions that's caught you and I? I'm aware if we can say, we go to Q&A for approximately 15 minutes so we can finish promptly at 8 o'clock tonight.
There's quite a few questions here, and I'm sort of trying to sort of pick through them. So we've talked about indigestion being associated with PKD, and this lady is really just sort of wondering what to do. First of all, what treatments should she have? And obviously has and that also comes with a large PKD belly, and he's really wondering whether to push for an MRI or a CT.
Yeah. So indigestion, this is coming from the quite physical force. So it's very difficult because there's no room. So that's why the stomach saying don't take food that much in one go. So you have to take in a kind of, how to say, little by little, so that you have to understand your body, how much if you eat, you don't feel much kind of indigestion or not. And that is a really difficult one, isn't it? So basically, pipe organs thing, it's very difficult to address in the Western medicine. There's no other better medicine for me. So the functional thing is very, very difficult, but you have to just take it little by little.
An interesting question's come in from one of the gents in the audience. Can cysts cause testicular aches in male patients?
Testicular ache. Oh, testicular.
Yeah.
It's a completely outside of the abdomen, isn't it? Well, it's not like inside the abdomen. My talk is all about inside abdomen, but testicular pain, maybe some other cause. It's not physical force, isn't it? But maybe some other cause related. I have to talk to those patients in each case. So but it's not kind of related directly, but maybe, yeah, pinched nerve, maybe some kind of related to the nerve. I don't know. I have to see the scrotum and see the patient. Sorry.
What about can kidney cysts cause cervical spondylitis in the neck? And also, this is from the same person. can it impair action of the vagus nerve? You got two there?
Yeah, okay. So neck is very difficult to cause cervical neck problem. Like I showed you, it's all inside the abdomen and the chest. And the chest is not much cyst. Some people have got cyst in the lungs, but it's very rare. So cervical neck pinched nerve, it's usually nothing to do with the cyst. So, but cervical pinched nerve is quite common. So it may be just common
Yeah.
presentation for the general population.
What about deferred pain, Yuki?
Sorry, referred pain. Referred. Cervical is very cervical, the local thing, isn't it? So it's not referred. It's a vasovagal. Did you say somebody vagal?
Vagal nerve.
Vagus, the vagus nerve.
Depends. If there is a cyst there, some people have got that anywhere. The cyst can happen anywhere, usually kidney and liver, but sometimes spleen, sometimes lungs. So if this is causing physically the pressing the nerve, yeah, it can happen. Depends on.
Yeah, and someone has asked about what can they do to limit calcification of cysts? Is it a matter of just drinking more water?
Sorry, calcification of the cyst?
Yeah.
So
If there's anything we can do to limit it.
Yeah, calcification of the cyst is different from the stone. Yeah. Calcification of the cyst is a outcome of the cyst bleed. So cyst bleeds come when the cyst is bigger. The bigger means there are more circulation there around the cyst. And then when they're bigger, they torn the capillary leak. And then that cause bleeding. That bleeds really make you quite have a sudden pain. But then the recovery phase, they calcified. It's not going to cause trouble, just the process of the healing.
Thank you for explaining that. And I'm sure Jane's eyes will be drawn the same as mine. As soon as you mentioned the word ibuprofen, I could almost feel the audience eyebrows raising, going, that's poison, we shouldn't take that. It's come up, a few of the message include that. So do you want to reiterate what you did and when it should be taken?
Yeah, okay. So ibuprofen, diclofenac, I call it NSAIDs. NSAIDs, chronic use, definitely no. But acute pain, like sometimes people haven't got any pain, but sometimes occasional sudden pain has got it. They have got it, isn't it? This is mainly, almost all the case, is a cyst bleed. And it will usually go away within a couple of days or so. If it's within a couple of days, up to 3 times, you can take it if you think this is really working for your pain. But like I said, there is a mechanism. So the kidney is full of filtration, like filtration. So filter the blood to the kidney. The filtration has got artery and the filter and how to say, efferent arteriole. And then this NSAIDs is afferent arterial constriction. When you are dehydrated, the afferent arteriole, the entrance artery, have to be dilated. But then if you take NSAIDs, it's going to constrict. So if you are dehydrated, it's really dangerous. So if you are not dehydrated, if you can drink a lot, because if you are nauseated, it's difficult, isn't it? In that case, don't do it. But if you know you're not dehydrated, you can drink a lot, you can take it, because it sometimes really works for the acute pain. If only a couple of days is okay. Yeah, but it's a very tricky one. So you have to talk to the kidney doctor.
Okay, so you're saying that short-term use of ibuprofen. Sorry, that for those that don't know, NSAIDs are ibuprofen.
Diclofenac.
But long-term use is not recommended.
No, up to 3 days.
They shouldn't be our go-to. Our go-to starting tablet should be paracetamol and ibuprofen or similar.
Yeah.
It's for emergency use only.
Yeah, definitely. But paracetamol is not work well to almost all people. ibuprofen definitely works, but please go to paracetamol if you can. But if ibuprofen works, only 3 days, very cautiously, if you're not dehydrated. The other thing is, can cause ulcer. So you have to take antacid as well. Or you can drink milk first and just protect inside lining of the stomach and then take it. So those two things, ulcer of the stomach and the kidney.
And I see in the chat we've got both Naomi and Jane asking about cyst bursts and what things can make a cyst burst. Could it be exercise?
Yeah, definitely. So cyst bursts happen usually bigger cyst. So usually PKD patient cyst is like a 1 centimeter, 2 centimeter in length, right? And moderate size is like a 4, 5 centimeter. And the big size is 10 centimeter. And if it's a moderate to bigger size, they can potentially burst. And then basically physical force can definitely exacerbate it. So yeah, I think each patient has a very good idea about your body. So you have to understand what's triggered it, what's happened before. You have to really understand your body because so different, variable trigger, variable presentation. And if the same structure doesn't sometimes explain the same symptoms. So it's all each case individualized.
And is there anything that people can do generally to prevent a cyst burst or bleeding? That's a second question. It's just come in linked to cyst burst.
Prevention.
Yeah, for bursts.
Prevention. Very difficult, isn't it? Prevention is very difficult. If you know you have a cyst more than 5 centimeter in length, it's a quite risky cyst. So if you know where is the cyst, be careful not to be punched. And also, usually strenuous activity can exacerbate somehow. So my only advice is if that happens, prevention is very difficult because if you are a very active person, you want to be active, isn't it? But if you know this up to this level of activity is okay, it's more than that, it's going to cause trouble. If you know the limit, is okay. But if it happens, like I said, there's no medically significant thing happening. And nothing you have to go to A&E, but all you have to do is pain control. So you have to get the pain medication at home at stock in case you have a burst cyst. So you haven't got a stone, if you have a temperature, you haven't got a temperature, this is basically cyst bleed or burst.
And David, while we're just talking about impact and movement, etc., David's asking, can non-direct impact cause pain or discomfort? And the example he's given is chopping wood. So I assume David's recently been chopping wood and experienced some pain. And if he's wondering if it's come from that.
Okay, sorry, I couldn't understand what you said.
David's asked, can non-direct impact cause pain or discomfort? And the example he's given of that impact is if he's been chopping wood. So he's been physically moving, chopping wood, and perhaps experienced some pain. David, have I got the gist of that question? Yeah, perfect.
So sorry, what's the question? What's the
David, when he's recently experienced pain following chopping wood, he's wondered if it's the impact that's caused that or even just the motion and movement.
Oh, I see.
Yeah.
So you want to know exactly what's caused this?
Yeah.
Very difficult to say. I will have to see your cyst first and what kind of movement you did. So chopping, isn't it?
Yeah.
No, I have to see the cyst and where is the cyst? But is that first time happens after this same movement?
Yes, it is. I'm getting a nod of the head. I can see David on my screen there.
And did you do that before, the same chopping, but it didn't happen? This time happened. Yeah. So yeah, it's a kind of unfortunate, isn't it? Because basically cyst is always growing in a micro level, and at some point there is some kind of limit, reach the limit, any movement cause burst or bleeding or some pain. So yeah, the body is always changing and a more assisted growth way. So I can't tell which exact movement caused that kind of part of the cyst. But sorry.
This is an interesting question. This lady here is asking about CRP levels, sort of C-reactive protein levels in your blood. If they're high, does that mean an infection and not a bleed?
Very good question. CRP is just an inflammation marker. Can be only inflammation. Yeah, bleeding can really push the CRP up. Infection definitely up. So can just by looking at CRP, almost all case high CRP is infection, but cancer patient has got some inflammation, so always kind of relatively high, like a 30, 40 CRP. But if you have a cyst infection, it's going to be high, like 300. And bleeding, yeah, 20, 30, it can, because of inflammation, isn't it? So yeah, it's a very good question. If you haven't got any spiking temperature, it's not infection. It's a medically significant infection. It's not that.
And a lovely question that's just come in from Maria. Is it safe to have massages from physiotherapists? I'm also going to say beauty therapists if we go for the gentle massage, whether and is there danger from it to break any of our cysts and burst?
Yeah, it's physically, it's a common sense wise, it's quite tricky, isn't it? Because you might touch the cyst because cyst is really here. Yeah, it can be, but not necessarily. So you have to experiment on yourself. Because if it's quite good for the massage, because massage is basically the musculoskeletal bits, isn't it? Not in the kidney massage. So muscle massage should be okay. But if the massage is too strong and to touch the system, if that cause some consequence, you have to think.
I'm thinking from personal experience going for general massage, I like the lighter touch. I don't like a firm sports massage.
Yeah,
so
true.
I think that's what it would come down to, just speaking with your therapist, explaining your medical history and asking them to take care around that area.
Another really good treatment as an alternative to massage, if you're wary of that, although I'd have one all day long if I could, would be reflexology. So you can get some real benefits from reflexology, but and of course you don't get any contact on the abdomen or the back, so you're thereby reducing any risk of harm to the
muscle skeletal shouldn't be inside the body, because inside the body is always protected by the rib cage, but between the rib cage and hip bone there's a little bit soft parts, and then that it depends on the patient. Cyst can be there, so if you do too much, there is no rib cage protect your organ, so be careful. But here should be okay, isn't it? Here it should be okay, isn't it?
Yes. Now I'm aware we've got 4 minutes left and the questions are coming in fast and furious into the chat, but I know there was a lovely one who had come in advance. It came in the last couple of days, and it was from Karen. And Karen wanted to know, as her kidney function drops, especially to an EGFR of less than 15, would she experience a change in pain levels?
Interesting. So if this EGFR less than 15 come mainly from cyst growth, this means cyst growth physically really pushed out the real parts of the kidney, isn't it? So that means cyst growth is very aggressive. And like I said, cyst growth, so all the symptoms usually come from cyst growth, physical growth, not like a chemical thing, not like hormonal thing, it's physical force. So yeah, I guess I imagine the pain it's a gradual thing usually. without having a burst or bleed. So yeah, BGL15 is quite aggressive, isn't it? I guess his kidney is quite big, enlarged, like a 30 centimeter.
And something that has recurred throughout the chat tonight is people asking about supplements and diets. Now, that is a very individual area and an area we really can't go into tonight. It's a standalone topic. We could be here for a week if we started. But have you any general advice about people with supplements? Is it a matter of speaking to your own consultant and be honest about what brand, what dosage, etc. you would be taking so they understand? Because I know at the moment it's so easy to buy supplements online.
Yeah, I'm taking vitamin D. Vitamin D is a good supplement as long as you live in the UK. The sun is not enough. So yeah, supplements okay, but if you have a hypercalcemia, you have to be a little bit careful. So you have to talk to your doctor. And the supplement, other than that, supplement, there's not much evidence, sorry about this. So I can't tell no or yes, apart from vitamin D.
That's lovely. Thank you so much, Jane, for dropping into the chat many of the links that we have, whether it's recordings from previous sessions, similar tonight, the sign up for our newsletter, or also a link there for PKD app. Now, I'm aware that we will be finishing our meeting very shortly, and you might not have a chance to click through them. I'll include them in a little email to you all tomorrow. It's been a wonderful time. But unfortunately, when we're having fun, it passes so quickly, and that's us just at the hour there. Now, I see there's lovely words of thank you coming in, and thank you, UK. It's yourself giving your time freely that really lets us do these sessions. And it's not just the hour you give tonight, it's the preparation that goes into those slides. We really appreciate that. It's wonderful. And I see Jane has dropped that link in for the feedback form. Jane, can you drop it in again? It's getting swamped by all the thank you messages coming in there. If you could click on that just now and perhaps take a moment just to complete it, it'd be fantastic. That's great. Thanks, Jane. And in theory, if you open it, it should just open another little tab for you to complete that. So thank you. Is there anything before we close the meeting, UK, that you would like to add?
Yeah, so there are so many topics to cover. I wish I could talk to you each one, going through each images. That's helpful. It has to be individualized medication, measures care, isn't it? And the other topic is tolvaptan. Other topic is UTI infection, cyst infection. I need to have another session. Yeah, I hope I can see you again.
Yeah, it would be lovely to have you back, especially for UTIs. Now, for those, tolvaptan, I was aware, came up a few times in the chat. Now, many of the patient-reported side effects do say a reduction in pain, and that's not why it's licensed, but many patients do report a decrease in their pain. We have some recordings available on our website on the topic of tolvaptan, and many of the topics that come up in the chat tonight as well. We'll share that link with you all. So that's it. Thank you very much. And with that, I'll say good evening. Enjoy the rest of your evening. Thank you. Bye-bye. Thanks for your help as well tonight, Jane. It's appreciated.